Hi, everyone. Thank you for coming to the Texas Epidemic Public Health Institution Infection Prevention and Control webinar series. Today, we will be presenting the Infection Prevention 207 Outbreak, which is a brief overview of how to determine and conduct an outbreak investigation in a healthcare setting by looking at specific infection prevention strategies, to ensure patient safety and staff safety while maintaining public health standards. So this module at first I will give, it'll be a little bit different if you've compared to the previous modules that you've come to the infection prevention series. We're going to do some brief background, and then we're going to go into a learning module. And at that time, we'll ask everyone to hold their questions until we get to the learning module, which is a case example of looking at application ways to apply what we previously talked about in a real world setting. This is a completely made up case scenario from working with different organizations of really things that we should be doing during an outbreak investigation. So I'm asking please hold all questions until we get to that area. And then we will have question and answers. During that time, we'll work through an example, and then at that time, answer questions along the way. So this lecture has been approved for 1 hour of continuing education for a certified public health professional, or if you are a certified infection preventionist and you have your CIC, this lecture is also approved for 1 credit hour to maintain your CIC, and we'll have instructions at the end of how you log into the learning stream, create an account to obtain your certificate of the lecture. And just like all the other lectures, this is recorded. It will be posted on the YouTube channel. And then within a week, you will receive an email with the slide deck and a link to the recording of today's material. So again, the lecture will be posted, the slide deck will be available, and it'll be mailed out within a week. Or you can go onto the TEFI website and access it on the TEFI YouTube channel. So let's start the presentation. So before I get into kind of an overview of infection prevention, outbreak investigations in our state study, I really want to just give you a brief introduction if you haven't come to a previous TEFI infection prevention webinar series of what TEFI is. And TEFI, or the Texas Epidemic Public Health Institution, is a state organization that's housed here at UT Health Houston School of Public Health. And its goal is to really keep Texans safe and the Texas economy strong by increasing our knowledge and resiliency, so we're better prepared for the next infection outbreak that will happen in our state. And at the end of the presentation, if you want to know more about TEFI, there's some QR codes, and along with additional informational links that you can go in and explore. There's many different cores of TEFI and different webinar series that you might find useful. So I implore you and suggest going and exploring what other cores are doing within the organization as well. So today our learning objectives are to describe and explain outbreak investigation, specifically in healthcare settings, in the infection prevention regulations, recommendations, how we conduct an outbreak investigation in healthcare settings. And then the majority of the lecture will be discussing step-by-step a case example of things that we need to be doing during an outbreak investigation in health. So again, please hold all of your questions until we get into that specific walkthrough case example that we'll go through step by step. There'll be some QR codes. We ask that you scan them so that you can answer the questions, and we can talk through some of them as well. So as a good learning cue, I just want to introduce a few basic terminology that we use in outbreak investigation, specifically our case definition, which is a uniformly applied criteria, with the caveat during an outbreak investigation, your case definition might change as more information becomes available. Anytime there is a new emerging pathogen, as you saw if you attended the previous TEFI lecture, emerging pathogens, as more science becomes available on specific pathogens, how its transmission, how long it's on surfaces, who is most at risk. Sometimes that case definitions through time will change, but in generally, it is a uniform definition, and it's really important to make sure when you're analyzing your cases and if you are doing studies um, or doing different types of analysis that you know what case definition you're using during the time point of symptomology or workup. So if you're using one case definition from March until May, when you're doing your investigation, your line listing, like you're writing that down and documenting that this was the case definition that we're doing, compared to then if as more information becomes available on the emerging pathogen or more clear as you get through your investigation that more information is coming to light, you need to modify your case definition. Then the next period of your outbreak investigation, say June until August, that you're using a modified case definition, that you make that documentation too as well. And then anyone that's doing longitudinal studies on these things, it really helps with residual confounding. And if you're doing any type of statistical analysis, to really account for that variation because your case definition, your workup was different during that time. Then we also have a cluster event, which is an aggravated cases, which is a greater than expected number. Our colonization, there was a question last lecture about if it's colonization or if it's an activated case. Colonization is anytime someone is positive for a specific pathogen that's not causing host damage to the host. So these are patients that will be positive for this, but they won't be symptomatic and you won't be actively treating that, but they are colonized and that pathogen is present on them. And then an outbreak, as that what we are concentrating on today specifically, as an increased number of occurrence in cases. And your outbreak number can be defined by your organization, by the local or state public health department as well. And that number could be 5 or 10, or it could just be 1, depending on the pathogen and the severity of the pathogen. So making sure that you understand these terminologies, but also the nuances with them, that they can be modified and you need to be aware of what you're working with. Next, control measures are measures that infection preventionists and other disciplines put in to disrupt and reduce the occurrence of the infection, reducing the spread, and kind of controlling it. Environmental sampling is when you're trying to identify if a specific pathogen is within your environment. You might take a specific swab, such as in a healthcare setting, and swab certain surfaces to see if that pathogen is present in the environment as a potential source of the source or the reservoir of the outbreak, of knowing that it's a specific area within the facility, it's not being cleaned right. And also you can use it to confirm that your cleaning methodology, when you're disinfecting it, you're using the appropriate chemicals to really get into that pathogens and kill it, to ensure that it's out of the environment. Our epidemic curve is a histogram or a bar chart that shows distribution of the pattern. And I have a couple examples of that. And line list is kind of like your guide that you're using to collect data during your outbreak investigation, specifically looking at demographic information, clinical risk factors, and other contributing factors. And I have a couple examples that we'll discuss later in the lecture. So our big question is, why do outbreaks happen and why do we conduct outbreak investigations? So many outbreaks in healthcare settings and even in the population can happen for many reasons. Specifically in healthcare, what this lecture is focused on, outbreaks can be caused by breakdown infection prevention control practices that can be due to policy change, leadership change, changing staff number changes, or say if you're switching products, say a certain product that is used to disinfect a certain area within your healthcare facility gets back ordered, or there's a shortage and you switch to another product and you don't specifically look at the metrics within that product to see what it's effective of, that maybe it doesn't kill the pathogen of interest, and then you are caused with an outbreak of cases. Unknown or known infectious patients or visitors. Sometimes that happens, that we have patients that are coming in, getting treated for one thing, and then we realize, oh, they're colonized, or maybe they are still in their incubation period and they're asymptomatic with the virus, but then on day 3 or 4 of the hospital admission or the healthcare admission, then they become symptomatic too, which we saw with COVID, with that long 21-day incubation period. That made things a little bit more challenging and outbreaks to happen. Contamination or defective products or devices, if high-level disinfection is not, or sterilization is not being conducted appropriately and effectively, or there's a defected or damaged device that maybe that's causing other issues. And then colonize or infected healthcare staff. So we have our patients, and then we also have our staff members, and we have our visitors that we need to be mindful of. People being colonized, which is just harboring pathogens on their skins. All humans carry pathogens on their skin, but we need to know what are good pathogens and bad pathogens. And then if they're in our incubation period, that we are asymptomatic when we're reporting for work, but that within 24 hours or maybe at later at the end of our shift, we're not feeling as well, that can cause an outbreak too. And the overall goal for outbreak investigations in the infection prevention safe is to really identify the cause of what is causing this issue, put good infection prevention practices in place to control, reduce, eliminate the outbreak. And then we want to switch over to the prevention side with our lessons learned of what happened, that we can create policies and procedures, guidelines and education and awareness so that these future events will not happen within our facility. And while we're conducting these infection prevention outbreaks investigations, we want to specifically keep in mind that very primitive infection prevention idea of the epidemiologic triad of infectious disease. And that is the relationship between our host, our agent, and our environment. And this is a very dynamic relationship, meaning that it can change based on your host, your agent, what pathogen you are working with in your environment, how you're cleaning, how you're disinfecting, who's allowed to come into it, air exchanges, those types of things. So when you're conducting your outbreak, make sure that you are looking at all of the things, the people, which is your patients and your staff members, the agent, so what's causing the issue in the environment, where is it happening, how's it getting in, what is our environment like. Those are all things that you always want to keep in the back of your mind when you're conducting outbreak investigations, so that you have a full-pronged approach when you are conducting, and so that you're identifying all areas and you're not missing a specific area of potential risk, so that you can eliminate the outbreak. Again, to the questions, please hold all questions until the end. Yes, the slides will be available at the end of the lecture, and within a week, they will be emailed out to everyone. Okay, so before you begin an outbreak investigation, the number one question you need to ask yourself, is there an issue? And this can mean to, just because you're getting increased positive cultures on specific things doesn't necessarily mean there's an issue. Or you go down this road of outbreak investigation, confirm that you haven't switched laboratory assays, you haven't switched laboratory companies. If this was an in-house test result and now you're doing to a third-party test result, you didn't switch PCRs, you didn't switch different laboratory message. Maybe this is a seasonal thing, such as influenza. Is this non-influenza season or influenza season? You're starting to see that uptake of that. That really wouldn't be an outbreak because that seasonal shift. It is the summer, it's hot. So now we need to start thinking about other pathogens that are vector borne with our mosquitoes and at risk, which still with our reporting ideas. So make sure that you are overall looking at the community, looking at your facility, and being just aware of what's going on in your county and within the state, and then nationally under the CDC recognition of what's going on. So if your question is there an issue? Then, and if you say, yes, there is a problem, we're seeing increased number of patient admits, we're seeing sick individuals, where our PPE is running out, our disinfection products are running off the shelves, and we're using more than we thought, we're at hospital capacity, or the lab is sending me more positive test results, then the next question is, what is the issue? Is this a supply chain issue? Is this a pathogen issue? Is this a workflow? Is this a cohort? What type of issue? And then asking, who is this concerning? Who needs to be part of this investigation? If there is a problem, who needs to be informed? What's going on? And when should I be informing them? When should I start the investigation? If there is an issue, do I start now? Do I let it wait for 24 or 48 hours? Do I start immediately? How severe is this investigation and this critical level of that we are identifying? What's our case definition? And then lastly, what are we going to do about it? So these are all good questions to ask that you kind of should already start having a feel for before you begin your outbreak investigation, which outbreak investigations are tailored to the specific pathogen and the severity of the pathogen. So if you are doing an outbreak investigation of C. auris versus West Nile, those will be looking different because those pathogens are different. They're transmitted different. Their mortality, their severity, their symptomology is different. But overall, how you conduct the investigation, you should do it in a standardized way. And there's two phases that you'll always conduct: the initial investigation and the follow-up investigation. The initial investigation has 11 components that we'll have to talk, and the follow-up has 5. Some of these components happen simultaneously, and depending on the severity, you can move them around. But overall, you'll do your initial and then your follow-up, but then you will tailor your investigation to the specific issue, the pathogen, the severity, and the critical, like the situation at the time. So for the initial investigation, your first step is always to confirm there's a presence of an outbreak. So that's knowing with some level of certainty that there is an outbreak going on. And that means looking at a specific test or maybe symptomology, or getting a piece of information that you're like, hey, this could be concerning. You have been on a state call, you've been on a county call saying that, hey, this pathogen is present. You've talked to your providers that they're starting to see an influx of patients, and so you're ordering additional tests. So the first is confirming there is an issue, which I know can be kind of hard. And these three, between confirm, identify, and verify, they kind of all happen at the same time. So you first want to confirm, like, hey, there is an issue that I'm concerned about. The next then is that you identify your investigation team and your resources. So at first you're saying there is an issue. What possible resources will I need to handle this issue, and start kind of acting instead of reactive, proactively. You're starting to see there's a problem, then making sure, like, we have our PPE, we have our staff, we have our policies, procedures, we know where to look so we can start handling the situation for the pathogen that's present. And then we're also letting our team know, like, hey, there could be a potential issue. So you're talking to your leadership at this time of, hey, there's a potential issue. We've ordered test results, which goes into the third step is verification. We have ordered test results and we are waiting for that positive test result. That could be a serology, that's a confirmation test, a PCR test. What is your verification of your diagnostic tool of looking at specifically? Is that imaging and laboratory works? Is that a physician assessment with laboratory? What is that? So 1, 2, and 3 kind of go together of looking at confirming there's a problem, identifying what you need to handle this problem. Is it PPE? Is it staffing? Is it negative pressure rooms? Is it cohorting a unit if you think that there's going to be a lot of people potentially affected by this pathogen? Is it if they are for staffing, you need to switch your staffing, which I know is not in the infection prevention realm, but when you're advising someone within your healthcare setting of, hey, this is a very infectious agent, high mortality, maybe just assigning one nurse or one PCA, one healthcare provider to that patient to handle it, especially if this is an emerging pathogen or a very serious pathogen that you will have a lot of involvement from local or state public health or potentially CDC. It's great that there's one person that you are managing that case, because there's a lot of follow-up that goes into working with our public health partners as well. And that third, you are verifying the diagnosis. So it's not subjectively of just a provider thinks it could potentially be this. It's that you have that clinical laboratory result with additional imaging and workup saying, yes, I am 100% confident we do have a case, and here's my positive test result. So then based on that information, step 4 is establishing a preliminary case of definition. So you're looking at what specific pathogen are you looking at and starting to develop a case around it. So what is the symptomology for this patient? Is it they're coming in with fever, they're coming in with hypertension, they're more flu-like symptoms? Are they hemorrhaging blood? Are they have a certain rash? You're starting to look at that. Is there any travel associated events with it? Is this something like in the beginning of COVID or some other pathogens with Mpox? Where have they been to a certain country where that there's a specific outbreak? If there is TB in your area, have they been to a region where there's known TB and or a higher incidence of TB, and then they come back and now they have a lot of pneumonia, pulmonary issues, they're short of breath, they have night sweats, we're working out TB. So you want to start looking at your pathogen, how the presentation and working around those types of questions. And then the next is to identify alerting of administration. So it's always great to, once you have identified a case and you know what you're looking at, you first tell your organization, hey, I think we have a case, and now I'm going to be reaching out to local public health for guidance. So always telling your healthcare facility, hey, this is what's going on. Also telling your providers, like, hey, we're not, you know, this laboratory test result was positive on this pathogen. Now I need to reach out to public health for our state reporting requirements to report this pathogen, and I'm awaiting on guidance from them. Because, you know, as an organization, we have things that we need to do for that at that organizational level, but also for local and state public health agencies coming in and partnering with them. They might have additional testing labs they want you to collect, not allowing you to discharge them out into the community based on the pathogen. So just letting your administration know. So your whole infection prevention department, the primary attending on that patient, whoever's overseeing the care, and then also administration at a facility level of, hey, we might have an outbreak with this pathogen. I've seen an uptick in cases within our facility. I'm now reaching out to local public health officers to potentially start an investigation. I'll let you know more what they have to say, and so that you can schedule time if they want to be on the calls with you when you're reaching out to local or state public health too. So it's a very uniform, collaborative, and everyone's in the know, so that we are properly identifying things and we're working together collectively to solve this issue and reduce transmission of the outbreak of the specific pathogen of interest. Next then goes into our literature review, or at this point when you're talking to local public health, they might give you guidance and they might already say, yes, this pathogen has been in the community. We've seen it at other facilities. Here's our handouts. Here's our things that we advise you guys to do. Or they might reference you back to CDC. They might give you a paper. So a lot of times before you start doing your own research, definitely ask for their advisement of, you know, what is their policy? Do they have handouts? And sometimes they do. So that you're already trying to contain an issue at the facility so that you're not wasting time looking up material when they have access to it, and they can send you specifically the local and state health material, that how they want it framed, what they want it to do, what your county is suggesting you to do in that space. Next, then you want to develop a methodology of your case findings. So that's gathering more information. That's looking at where the patient's been, looking at epilinks, when they were admitted, their room location, their unit location, all those things, that their symptomology, getting a more comprehensive medical history, where have they been. If this is a patient, have they been in any other healthcare facilities? Have they been in acute care, long-term care, or a nursing facility? Gathering that information for your case definition is really imperative at this time. Also documenting when you started isolation measures, when you notified public health, that's always good record keeping as well. And then that will lead you into your line list and your epi curve. So you're gathering information, you're collecting it, you're knowing who to look for in detail specifically, and then you're kind of widening your net of, like, maybe you need to then look at additional criteria, or say if this is an outbreak within the community and we're starting to see patients influx, such as say there was a concert event or a festival or picnic event and there was tainted food, and we have a foodborne pathogen now in the community, and now we're seeing severe nausea, vomiting, diarrhea patients as well. So that during your case methodology and during your line list, when you have patients coming in with nausea, vomiting, and diarrhea, you're asking them, were you at this event? Did you accept food from anyone at this event? So that you're asking those additional questions that really aren't standard of care, but you're having a more comprehensive idea of who and what you're looking for. And then at this point, additional things that you need to be thinking of and working with your leadership and why it's so important is looking at staffing. If this is an outbreak investigation, did this happen outside of the facility, within the facility? Our staff that are handling these patients, what level of isolation do they require? Is it just contact or is it airborne as well? So knowing their staff loading and then also reducing the risk of exposing other patients due to lack of proper donning and doffing. You might want to talk to your nursing lead and your physician lead about who is seeing this patient and maybe reducing their staff. But also, I mean, that's not in the infection prevention's realm of recommendation, but just having those types of conversations with individuals to make sure that we're alignment and we're really keeping our staff safe and we're not accidentally exposing our other patients. You also want to talk about patient throughput. If these patients are showing up in the ED, are they staying in the ED for a long time? Do they get a higher priority and they're getting admitted? Are we then cohorting patients? Are we putting them on a specific unit? Are we putting in different zones? Do we need to change our air pressure within our specific units? Are we doing zones? Are we doing like a full unit shutdown? What is the overall plan? Do we just expect a couple of these patients for this outbreak, or are we expecting like 5 to 20 to 30 patients? What does that look and how operationally are we going to be doing that? And then also during an outbreak events, if it has to do with lack of identifying them on admission and they've been in the facility for a long time and isolation hasn't been established, you will then have to do exposure events and specifically a contact trace. So you will have to trace where the patient has been to know what areas need specific disinfection and certain products cleaned in that space if it's not standard of cleaning in that area, and then also what staff came into contact for the staff safety, and then also if staff weren't wearing isolation when they came into contact with this patient and then they saw other patients with their ratios, did they potentially expose other patients because they weren't identified? So we'll do contact tracing in the next module. We'll use the same kind of case definition and we'll look at application. So we'll break down of doing the different contact tracing and kind of the overall back of contact tracing exposure in lecture 208. So next month's lecture. So you'll do your unit and your staff. So here's an example of a freely available line list template that you can look. Additional things, this is on the CDC site and the reference is down at the bottom of the slide, also in the references and resources at the end of the lecture. Additional things to add to this case definition for your line list is date of admission, unit location and number specifically. That will be very helpful if they're moving around. So when you're doing your contact trace that you know where the patient's been. Laboratory results, surgical procedures, date of isolation started, that's always a big one, and then discharge date, along with any other information that you think is important at that time as well to hopefully streamline it that you are identifying patients sooner than later. And then going on the next steps of getting them in isolation, getting labs, and then treating them for the specific pathogen of interest. And then here's an example of an epidemic crew. It's usually a histogram, which means that the bars are touching, but for visually, I wanted to space it out so you'll see a little bit of the pace, but you can see the nice peak on the graph where the peak of the outbreak was on day 7, which is the highest point with the number of cases. And then you kind of slowed to see it down. So over a 14-day time period at the bottom, you see the number of case counts go over the 14 days. So you can kind of see visually how your cases were trended within your facility. And then next, after identifying what you're looking at, what isolations are required, then you are then putting those infection prevention standards in place to reduce the spread of transmission. So that's specifically going, like you have your positive test result for a specific pathogen, then you are confirming they're on isolation, they're getting this treatment, staff are donning and doffing, they're washing their hands, disinfection for that room is being done appropriately. And this is where you're physically going and reviewing, confirming through audit process for direct observation with huddling and staff that these measures have been in place and that you're reducing the spread. Next, then at this time, you can consider environmental or healthcare personnel sampling if that should be performed, if we think that this is the environment, or if we have a colonized healthcare individual, or if we had a symptomatic healthcare individual come in and expose people. During this time, before you start this, always talk to your leadership about this because this can get very costly very quickly, and this will be at the healthcare facility will cover the direct cost. So that is something that you need to go talk to your leadership before you start doing and making sure that everyone's on board with this. And then additionally, if you are swabbing or having tested healthcare personnel, you are talking to your HR department, in your risk department too, of if this is a personnel, and then with all of our HIPAA requirements and our occupational health safety and our occupational health director, you're bringing them in as well to make sure that they're on board for this and that they agree that, yes, we should be swabbing our healthcare staff as well. So it's a big discussion. A caveat with environmental testing, there's always pathogens within the environment. So it's always a little tricky of should I swab, should I not swab? Because you are going to find something. And if you find something, you need an actionable plan to address it. So just be mindful of that. You might find something that you weren't looking for, but the more culture and the more assays that you're going to find, there's more bacteria, viruses that you're going to find. So just be ready for that if that's the plan that you chose to take. And then at this time, implementing initial control measures, all three of them kind of go together, just like the first three of the initial investigation, the observe, consider, and implement. They kind of all happen simultaneously. So then you are implementing initial control measures. You're also observing them. You're seeing what's going on. During your observation, you also want to see what's going well and what's not going well. So maybe that's an issue that led to the outbreak, is that, you know, people weren't performing hand hygiene. They were reusing PPE. They weren't donning and doffing. They weren't using the right disinfectant. They weren't using the contact time. So during observation, like, you're asking those questions as well, and you're observing how people's normal flow, and then asking, like, is this the same on day and night shift? Is this with this patient? Is this all the time? So asking more of those exploratory questions so you can get a full comprehensive picture of what is going on within the facility for that specific process. And then the overall goal for the initial part of the investigation is to identify, reduce, and eliminate. And we want to make sure that we are using multidisciplinary input, because what you know and how you see it might be different than someone else. So very collaborative. So using your nursing partner, your physician provider partners, your EVS, your secretaries, anyone within the unit, your PCAs, your CNNs, all of them, making sure that you're getting input so that you have this very comprehensive picture of what's going on. And then be strategic when you're implementing changes. You can't just start and change 20 things and hope one sticks. Be systematic with it and be strategic of identify the priority of, or a new change of process that might be the most beneficial to do. You want to implement that before going on to the next thing. That's also, like, to show effectiveness in training and education. If you roll out 5 new policies, that's kind of a lot for staff to read, to understand, to re-educate as well. And the same with your workflow. And then in the follow-up period, after the investigation, you will define and redefine your case definition based on information that's provided. You'll continue doing case surveillance and findings. So you'll trend it out and you'll keep on looking for that pathogen for a while. You will review those control measures that you implemented, and maybe some of them can be reduced. Maybe we're at a good place with our case count, or maybe those new measures that you implemented need to become policy and standard of care and recommended throughout time. And then you want to maintain your other surveillance activities. So not just this pathogen, but all the other pathogens and all the other things in the infection prevention space that we continue to do. And then lastly, consider, you know, what you did and what you found. Should an analytical study be performed? Should you do retrospective case analysis, definitely talking with your hospital epidemiologist, the local public health of what are next steps. So during the investigation, communication is key, is communicating that this is a potential to all stakeholders, both within the facility and outside of the facility, that there is clear, direct communication. And this is a continuous process that you are following up, you're touching back to really make sure that everything is handled. And then to be able to do this well and have good communication, it does create robust partnerships between you and the local and state public health department. I mean, we are all on the same team, and our goal is to make sure that our patients are safe with great care provided to them, and our staff are safe while taking care of these infectious patients. And then here's just an example of a CDC data collection sheet that you can use for your reference. Again, slides are posted. You'll have the link is in the reference deck. So now we'll talk through a specific example of how to now apply these things that I'm just talking about. So I would like all of you to scan the QR code, and we're going to go through step. And then at this time, if you have questions, please put them in the chat before we move on. So we'll do, just like previous infection prevention lectures, we'll do 10 questions, but based on the information that I provide you, we can talk about next steps and how to really implement these things. So you can scan the QR code, and then on the screen, you'll see the answers when you submit at the last question will show on your screen. And then also at the end of the slide deck that's posted, you'll see the answers as well. Okay. So at the beginning, the start of the scenario, we have an 80-year-old male patient brought in by ambulance from a nursing home facility to the emergency department on this date at this time with chief complaint of shortness of breath. It started in the morning, it got significantly worse, and now they are being seen in the ED, and they are going to be admitted from an outpatient location of your emergency department into your ICU. And just some brief background information is that patient is a resident of a skilled nursing facility for the last 12 months. They've been at one facility for the last 12 months. They have a pacemaker and they have a chronic Foley catheter. And then their pertinent medical history is that they're hypertensive, hyperlipidemia, and chronic kidney disease. And so that chronic kidney disease kind of shows reason why we have a chronic Foley for that. Okay. So day 1 to day 3, they go from the ED to the ICU. They're assigned in the ICU. Your ICU is a double occupant room. So there's 2 patients in a room. They have a cardiac workup because they complain of shortness of breath. So thinking cardiac or pulmonary. Their cardiac workup is unremarkable. Their chest x-ray, unremarkable. So cardiac and chest-wise, they look fine. There's no edema. There is no cardiac. There's not an MI. And then we are starting to order labs. So we do our metabolic functions specifically, and then we're ordering on day 2 of admission, then we're ordering blood cultures, urine cultures on day 2. And then here's a picture of our cultures. So before you even begin, you are aware at the time of this thing that there is a national shortage of blood culture. So this is our HAN, this is our Healthcare Advisory Network, or our HAN, that went out last week on July 23rd. So there is a national shortage of blood cultures. So knowing this information and keeping up to these current events are very important, especially when you come into a critical situation of, okay, so if we have an event, we already know our resources are limited. So what are we going to do? And so when there are national shortages of critical devices, such as our blood culturing tubes, you are having those conversations with your central supplies and then your unit resources of, well, is there a back order? Is there a substitution? Can we use another brand? What are we doing? Do we use this brand at our facility? Do we not? Do we go with something else? So always being aware, especially that if you're going to know what's going on, it's good to know where your resources are in the infection prevention state is at all times. So just keep this in mind, that it's always important to have those conversations, and you need to be doing that as your current workflow, knowing their shortages and making sure that you are getting and reading your HONs. You can go on and register them online, or you can have someone in your facility forward them to you as well. So day 4, on admission, patient's been in there for 4 days now. Patient is still not awake, not coherent, cannot give verbal report. You're talking to a family member. The nurse at the bedside is talking to a family member, and they remind you, oh, yes, from the original note saying that they're from a skilled nursing home, now they have provided you with a name. The patient comes from Summer Rise Nursing Home. And as the patient's family member is disclosing this to the nurse remembers, I remember from a huddle a couple months or weeks ago that Summer Rise Nursing Home is a known C. auris outbreak facility, which is usually something that we know last hand. So on day 4, when she is obtaining this information, the patient now is febrile. They have spiked a fever. They're at 100.5, which the NHSN definition is always fever defined as greater than 100.4, or for our Celsius, it's greater than 38% Celsius. So obtaining this information, they come from a C. auris facility. It's day 4. Now we're spiking a fever. They have a Foley catheter, a chronic Foley catheter. She is concerned and calls infection prevention for guidance. So my first question to all of you, does anyone have any questions so far with the information that I have provided? Very limited, because that's usually how outbreak investigations go, is that you get a small subgroup of questions. So if you have any questions up to this point on the information that I provided, please put it in the chat. Okay. So my question to the group now is this concerning? And feel free to put your answers in the chat. Is this concerning that we have a patient that has been in our facility for 4 days that comes from a known C. auris facility, which we know is a very hard fungus to get out of our facility, and the isolation practices have not been implemented since they've been here for 4 days? Yes, so this is very concerning. The next one would be, would a patient be only admitted for 4 days is a long time for no isolation. Or sometimes depending on the pathogen, it could be depending on a few factors. Okay, great. I see a bunch of you. Yes, it is concerning. Awesome. So as we recall, if not all of you attended last month's lecture, C. auris is a highly transmittable fungus yeast pathogen. It requires enhanced barrier protections, clown gloves, mask. The recommendations from CDC is single patient room. We need to disinfect specifically with EPA list P products. And also for Texas, it is a notifiable condition. And within 1 day of receiving a positive C. auris test result, we need to notify local public health and then send in specific swabs for genetic sequencing on this pathogen, so that we can know its genetic makeup and identify where specific locations, if it's the same pathogen, different pathogen, or if there's genetic variability with our C. auris that we are seeing within our state and within our counties. So day 4, now that she knows, oh, they come from a C. auris, they're symptomatic for infectious workup. Now they have fever. We need to initiate isolation measures. So they were in a double occupant room. We need to move them now to a single occupant room. And at this time, the same time, the neighbor of the C. auris patient, who we think is C. auris, because we haven't confirmed, but we're like, they're symptomatic, they come from a facility, they have an indwelling device, which is an additional risk factor for C. auris, they could have C. auris. The roommate is now becoming symptomatic. So at that time, now ordering blood and urine cultures. And at this step on the unit of knowing, hey, this is a really robust pathogen, knowing that we have a shortage of blood cultures, of taking the approach of culturing everyone on the unit. Do we just culture people that become symptomatic? Do we just culture people that were admitted on the same day of that patient? That's a big conversation that you want to take into consideration at this time. So maybe you need to order more blood cultures or not, but before you do that, definitely looking at your leadership and talking with them when you're making those calls. So you want to make sure the roommate, we're ordering blood cultures because they were admitted for something else. They didn't have blood cultures done. So now we are ordering blood and urine cultures on them. Isolation measures are on the roommate. They're in separate rooms. Okay, that's day 4. Day 5, 2 additional patients on the unit. So now we have 2 patients. Our index patient has had blood cultures ordered and collected. We have our roommate of the patient, their blood cultures have been ordered, they're on isolation. We have 2 additional patients now that have fever in the same area. They were diagonal from the individual. We're ordering isolation and we're thinking, oh my gosh, this could be an outbreak. So at this point, we have a lot going on. We don't have any definitive information at this time, but we're thinking this could be something. This also could be something else. Maybe there's something else going on in the community. Maybe they're having fever due to their infectious process, what they're admitted on. And so until you have verified that, step 3, until you have verified that process, you can't really go forward. So 1, you want to make sure blood cultures are ordered and you specifically talk to the lab or confirm with a provider. We are looking for C. auris, and that is directly communicated to everyone. Hey, this patient is from a known C. auris facility. We are looking at this specific pathogen. You might want to call down lab to see if you can get like a hot priority or a rush priority. C. auris does take a long, it's a yeast. It takes a while to grow out sometimes. So, it might take a couple days, but definitely having that good communication of like, you're looking for this specific result for these specific patients, isolation. And that goes into your huddling with your department saying like, hey, this could be a potential issue. You're talking to the ICU unit of, hey, this could be an outbreak. We've ordered our tests. We need to be on isolation until we have test results. What type of staffing can you have to reduce the transmission spread? And then also EDS of letting them know, hey, we need terminal cleans on these rooms and we need to confirm that we are using EPA list appropriate products that are effective with C. auris. So now day 6, we have more patients on the unit that are becoming febrile. Again, it could be something else or it could be C. auris, we're not sure. Day 7, 2 more additional patients, and our index patient on day 7 has come back as culture and PCR positive for C. auris. So now we know, hey, this is a pathogen of interest. We need to report it. We have 1 day for that reporting requirement to the state. Let's talk to our team before we communicate with local public health and also be transparent of what's going on. Of, hey, we've had this patient. They weren't identified on admission for coming from a C. auris facility. We might have an outbreak, and these are the steps that I've taken. So you're circling back. Now you have obtained the cultures, all the patients that are symptomatic at the time, you have those cultures. It's been communicated to lab. It's communicated to the providers. If you're looking at the specific pathogens, other sources of fever are being ruled out. You have talked to everyone within your facility of who's involved, of what's going on. And now you have this positive case and you're confirming with the people that need to be involved. And again, maintaining HIPAA regulations and confirmation as well, that this is HIPAA, this should not be directly shared, but people need to know so that they are compliant. So at this point, who are we alerting? We have our positive case. Is it my organization? Is it local health? Is it both? Or we're not telling anyone at this point? Yes, that's great. We are now, since we have that positive case and it's a notifiable condition within that 1 day, as we talked about, we are now notifying it. And so how many days do we have to report this? As you've just heard me say, how many days? Yes, 1. C. auris on our state notifiable condition is 1 day within reporting, 1 business day of calling them, and it's a phone call of, hey, we're calling them and letting them know we have this case and we potentially have this outbreak, and telling them. So here's our reporting form, if you recall from the last lecture. Next, in our workup, we have identified our case, our index patient. We know what the cause was already, is that they have come in from a known outbreak facility that might have led to their admission. We did not establish infection prevention measures on admission, and then we are alerting our IPC leadership, our organized leadership, and our public health officials. So now we are all knowing. We are communicating, we're having calls with them, getting guidance that, hey, we might have an outbreak. So far, we have one tested positive, but because of this could cause other issues. And at that time, then they might be providing you guidance of, cohorting, staff ratios, products. Someone from the local health department might come into your facility to look at cases, to review infection prevention protocols with you. So just be open with them of what is going on, be transparent, collect good data, and they might provide you with additional steps and guidelines. So day 8, then we're having one more patient become symptomatic, and our patients 3 through 4 are now testing positive. On day 9, no new patients are febrile, so that's a good sign, but our patients 4 through 7 have tested positive. And day 10, no additional patients to the ICU are fever positive, and patients 8 through 10 have been confirmed positive with C. auris. And at this time, because it's specifically at your ICU unit, talking with leadership, do you need to close down the unit? Do you not? Do you need a divert transport? Looking at it as an organizational, operational level, you need to be having conversations with that. That's not under the infection prevention purview per se, but you can give recommendations of either cohorting, shutting down, limiting, to see what types of resources that is going on at your facility that you have access. Are you part of a system? Are you a standalone? What would be the best thing and safest for all the patients and all the staff? And these are conversations during these times that you should be having with your leadership in your C-suite. So what's the next step after a literature review? Do we develop our case finding? Do we prepare a line list? Do we do our epi curve? Or do we observe current practices? Yes, so that's great. We want to be developing our case findings at this time. Specifically what we're looking at, are they from a certain location? What type of risk factors do they have? And that will go into your line list and then your epidemiology curve that you'll develop. So for our case review of what we're looking at, so here's just more information. Brought him from ambulance. It was admitted from a C. auris facility. That's kind of our case definition of what we're looking at. So when it goes back to screenings, you should all have a screening protocol within your facility of what additional things that you are looking at for specific pathogens. For C. auris, we talked about last lecture about different risk factors, such as asking them where they're coming from, asking EMS where they're coming from, working up like locational factors of your screening protocol. Especially that C. auris for this specific pathogen of interest. It is known at some facilities, and that we've had outbreaks at other facilities, that if you know, like, hey, you're getting admitted from, for this example, that Summer Rise facility, on admission, for your screening protocol is they're coming in from a known C. auris facility, you're putting them on isolation, and you're culturing immediately on admission. So having that criteria built out into what you're screening on your specific pathogen can help really establish infection prevention practices in the beginning so that you don't have outbreaks. That's why it's important to have screening protocols for specific pathogens so you don't have an outbreak occur. But an excellent question. So then going more into our case finding, isolation was not admission on admission. No screening was performed on admission because we didn't know what facility that they came from. And sometimes that happens. Sometimes it's brought in from a skilled nursing home, oh, it's that they had an outbreak or this is a known facility. Sometimes that crucial information is admitted. Multiple items were used. So like their blood pressure cuff, there was an isolation, there could have been things shared between patients. The staff weren't wearing PPE because we didn't know that they were coming from a known CRS facility. So isolation wasn't implemented until day 4. And then we're unsure if EPA-P was used. So at that point, when you're doing your case definition, calling your EVS to say, hey, the last 4 days in that room, what have you guys been cleaning with and can you confirm that? So definitely following back and following up with your partners of confirming what is going on and what's being used, and then obtaining that data so that when you're talking to local public health, you can say, yes, we were cleaning, we weren't cleaning, we didn't know. And so you're having a complete picture. So here's our epi curve from the cases from this specific example. You have our initial patient, and then you have our trend throughout our cases. And then based on that information, what was the peak day of the outbreak? So what number of day were the most cases reported? Yes, great. It is on day 6. And what was the total case count of this? So how many cases did we see? Yes, we had 10 cases in our facility just from one patient being admitted, not symptomatic at the time for infection, but because isolation wasn't implemented on infection, it led to 9 additional cases being found. And then here's just an example of a line list. This is all made up information. This isn't from a previous facility. This was just imaginary, but this is what it should look like. You have your patient identification number, your name, your age, your sex, admission date, symptomology, diagnose, other comorbidities. Additional things will be added, but this is just kind of an example of information and how you would collect it that on your line list. And then next we're going into our reserve. So at this point, like we know we're implementing isolation, we're observing hand hygiene compliance, PPE compliance, disinfection protocols. At this point, are you going to allow visitation and talking with your leadership for our CRS patients to reduce the spread? Should we allow visitors, not visitors? What does legal say? Having those conversations too. And then because we've had patients move around and we didn't have isolation implemented at the beginning, the next question is, should there be environmental or healthcare worker sampling? So that's our next question. Is at this point, do you think we should conduct environmental sampling? Let's wait and see. No, it's not needed. Yes. And there's a lot of different approaches. I mean, for me and my professional guidance at this time, because that patient was here in our facility for 4 days and CRS is a very tough pathogen, I would say it would be great to do environmental sampling. But again, when going back to what I previously said, with the cost and what's going on, definitely having a recommendation and taking it to your leadership to see if they agree of what next steps will be set. So then next we're implementing best practices. We're looking at other things to consider is unit admissions, our visitor allows, confirming our infection prevention practices, auditing, and then also incorporating recommendations from public health professionals. What does local public health have to say? Are they wanting us to do additional things? Do they want us to shut down the unit? What is their guidance at this time? So definitely working with them for their recommendations. So then now we have observed, we implemented things, we got it under no new case counts for 30 days. We're observing our hand hygiene, our PPE compliance, and our disinfection protocols. So we're doing black light testing to confirm that there's no pathogen within our facility. And then we're also doing that environmental sampling, and there's no pathogen detecting. So at this point, is our investigation over? In 30 days, no new samples. Are we done, or should we do a couple other things? Yes, that's correct. We're not done yet. We needed to do that post follow-up of the investigation. So That goes into our follow-up of defining, continuing, reviewing, maintaining, considering. So redefining and defining our case definition for our CORs, continuing surveillance, reviewing our CORs policies, procedures, and disinfection protocol, maintaining our surveillance and our screening activities, and then deciding if we need to do an analysis. So based on what was going on for this, what are some improvements that we can make from this investigation? Building a screening protocol, improving communication, both C and B, or nothing, everything was fine. So yes, it's great. C, definitely, after you do an investigation, lesson learned, you want to make sure then you are flipping on the prevention side and then implementing it. So one recommendation is that working with your bioinformatics team or your people that build your EMR to build about a specific screening protocol. So new admits are looking for certain things when you are looking at a pathogen of interest, and then you're putting additional risk factors, which we talked about specifically for CORG's last lecture. And here are those risk factors. And then doing your composite. I know there was a question about screening protocol, but building this into your system so you know who you're looking at, who is a risk factor, and then how you are collecting your specific samples for this pathogen to see if they're colonized or if this is active infection. So then the last thing that you can do is staff education, show them the new EMR screening protocol that has been built, go over, answer questions, review the policies, and review your cultural collecting process with staff, because if you don't educate on them, they don't know that it's being done. And then lastly, our last question before I open it up, I know we're a few minutes over time, but how can outbreaks be prevented? Yes, that's great. D, all of these things: hand hygiene, early detection, and implementing good infection prevention practices. So as you saw with this example, having effective infection prevention practices is really key to eliminating outbreaks. And as we go through different periods of time in healthcare, there's going to be outbreaks, but having multidisciplinary collaboration, being clear, knowing what to do, being aware of what resources and staffing we have in our facilities that can really help keep our patients safe and our staff members safe. So here's the answers. I ask you all to connect with us. Here's just our information. If you feel free to email us specific questions. Here's some QR codes to additional TEFI material. In September, the TEFI organization is having their annual summit, specifically looking at zoonotic health. Risk factors as well. So that open registration is open, and you should be receiving a link to register as well. Some previous lectures for TEFI, and this lecture has been approved for a CPH 1 hour continuing education and a 1 hour CIC approved continuation through CBIC, and these are the ones. You can go through your dashboard to complete this process, and there's in a week when you get the slides, there will be instructions of how to go through to obtain your certificates. And then lastly, next month module is going to be contact tracing, specifically how to conduct it, kind of explain how, and using this example too of that step in the outbreak investigation, how to specifically do. And then lastly, I just asked you guys to complete the post-survey evaluation module. QR code is here. That really helps me create new content, making sure that this is clear, this is effective for you guys, and kind of provide you with topics that you haven't seen. All of our TEFI lectures have been recorded. They're on our TEFI YouTube channel. You can go back and watch them whenever. So definitely check that out if this is the first time you've come to one of the TEFI lectures. And then please fill out the post-survey evaluation. If you do, and you provide your email address, you'll be entered into potentially win some TEFI swag that we'll have emailed to you. And I just want to say thank you all so much for coming to the lecture. I'll open it up for questions. I know we're a little bit over time, and I apologize for that, but thank you again for coming, and I will open it up for any specific questions at this time.
There's a question in there. Do you recommend disposable trays are needed for CORS, or do you feel hot water and detergents in dishwashers are sufficient?
I mean, that's an excellent question. Are you talking about meal trays, I'm assuming? for that. Anytime you can go to, specifically with C. auris, because it is such a highly transmittable pathogen, anytime you can go down to single-use items, that is the best and most recommended device. So single use, like meal trays, not being in any communal settings, decreasing their movement in the hospital. If you can do anything at the bedside, that's always best recommended. So doing plastic trays, plastic silverware, all of that, that is what I would recommend if you're due to your resources. If you don't have single-use items, definitely confirming that your utensils are being ran maybe in a special cycle at specific, like confirming the temperature and the detergent that's being used. So either single use or confirming with the kitchen and like that tray isn't being sat in your kitchen for a long time or it being set in a certain area, that you're really reducing the spread. So sometimes the single use items just make things a little bit easier for these very highly transmissible pathogens. And yeah, to the comment in the question, it's up to your facility. I mean, again, infection prevention is very tailored to your specific facility. So definitely follow up with your facility of what your policy and procedure says. Do they say that staffing for C. auris patients is a 1-to-1, or can they have other patients? Are there hospital issue scrubs? Are they using disposable meal trays? That can all be built into your policy. But if it is built into your policy, make sure then you are following it to the T, because during your triannual or during an audit, or if local health department comes in during this time and they'll ask to see your policy, and if you're not following it, that can lead into big issues. So definitely circle back with those specific areas, such as kitchen, dietary, to see what the process is and what you have available, and go forward with that. But excellent question. Any other questions? All right, not hearing them. Well, I just want to say thank you so much for attending. And
We did have one
feel
last
free-
minute one just pop up.
Yeah.
I've recently read a peer-reviewed article about the use of UVC for C. auris, which proved to be a positive result. What are your thoughts?
Can you repeat that, Dana? I didn't hear it. Sorry.
Oh, I'm sorry. This person stated, I recently read a peer-reviewed article about the use of UVC for C. auris, which proved to be a positive result. What are your thoughts?
I haven't read that review. I have seen that, especially at APIC National when we were there, when I was meeting with some of the vendors, that some of the UVCs are being effective on C. auris. My thoughts are, at that point, extra cleaning is always recommended. If you want to do a specific disinfection with that list P and then UV, that's great. But that's something to specifically talk about your facility, and then also else your EVS department, because they might have thoughts and feelings on it too, of how effective it is, if it's effective with their rooms, or you're concerned. So definitely get buy-in from them. You know, they are the specialists in that field as well. You can bring those conversations and those white papers to a lot of policy development of talking about it. But see what everyone is comfortable. Sometimes they want to do both. Sometimes they just want to do one. Sometimes they want the UVC is specifically with certain robots. Does your facility have that robot, not robot? So read that very carefully and see what specific resource that you have in your facility that it's aligned with that. And then also administration and operationally, you guys are comfortable going with that. It's not as the infection prevention is kind of a very gray sometimes area. So it really just depends on multiple factors when you're evaluating things, but it is a great thing to bring white papers and ask your EVS department of, hey, have you read this? What are your thoughts? Do you know other colleagues or facilities that use it? Has it been effective? Has it not been effective? Always ask those questions and get their buy-in. But any other last questions? Okay. Well, thank you. And just to say again, within a week or so, you will get a link to the recording along with the slide deck. Everything is recorded. You can go on to TECA YouTube channel. The previous lectures are there. If you want to go back and do continuing education at the end of the module, it does give instructions of how to get your certificates for your continuing education. And I look forward to seeing you all next month on September 5th, talking about contact trace specifically within, we'll use CORS again and kind of do like a quick overview of the outbreak and then how we would contact trace the specific units and the staff in that setting. So thank you all, and I hope you have a wonderful Thursday.